Today we'll be discussing the surgical techniques and perioperative considerations for transurethral resection of bladder tumors. I would go so far as to say that TURBT is one of the most common yet underappreciated urologic surgeries. And in addition, there's a wide variety of practice patterns within Vancouver and within BC. And of course, our urologic care should be evidence-based. Our objectives today, first we'll briefly reinforce the importance of a complete initial TURBT. Then we'll discuss major decisions that need to be made during every resection. We'll start with enhanced cystoscopy, including some experimental agents. We'll then watch a few videos and discuss the evidence behind Bloc resection. And then to wrap up, we will briefly cover how to manage tumors involving the Ureteric orifice, as well as discuss the role for single-dose intraoperative intravesical chemotherapy. First, we'll briefly get a historical perspective showing leading up to modern TURBT. Back in 1879, Dr. Nitze from Germany first developed a cystoscope. Pictured here are two of his prototypes. For reference, this is actually the same year that Thomas Edison invented the incandescent light bulb. The next major advancement was Dr. Beer from New York, where he completed the first endoscopic treatment for bladder malignancy in 1910. At this point, he fulgurated two patients who presented with gross hematuria and had bladder tumors, and this was published in JAMA. He did this using a Nitze cystoscope and a copper electrode. The first resectoscope was subsequently developed by Dr. Stern in 1926. And this was further refined by Dr. McCarthy in 1932. You can see, looking at the photo here of a McCarthy resectoscope, that it is shocking how little has changed in 90 years. Moving forward to discussing non-muscle invasive bladder cancer and TURBT in today's context. Bladder cancer is the 5th most common cancer in Canada, and of this, non-muscle invasive disease accounts for 75 to 80% of incident bladder cancers. Bladder cancer is the most expensive cancer to treat, and this is measured on a basis of cumulative cost per patient from time of diagnosis until death. This is based on a 2006 estimate from the States. And a quote here that I think is a key take-home point from Dr. Babjak, who is the chair of the EAU Non-Muscle Invasive Guidelines Committee. He says, the most important modality in the treatment of non-muscle invasive bladder cancer remains a complete and precisely performed TURBT. Briefly just highlighting the guideline statements regarding the importance of a complete TURBT. Starting from CUA, they talk about the initial TURBT is of utmost importance. Looking at the EUA, AUA, they say complete TURBT is critical in the management of non-muscle invasive disease. And the EAU, complete resection is essential to achieve a good prognosis. Now, there may be some concerns about complete resection and risk of bladder perforation or tumor seeding. Sort of a separate topic. I'm happy to discuss that later in the talk. First, we'll discuss the role and options for enhanced cystoscopy. This will include blue light cystoscopy or Cysview, narrowband imaging, and then a few evolving molecular imaging agents. So first, blue light cystoscopy. This utilizes an intravesical agent which fluoresces pink when exposed to certain wavelengths of light. And much of this research actually comes from the neurosurgery field, where 5-ALA is used intraoperatively for resection of gliomas. Now, the mechanism of action, hexaminolevulinate, is an ester of ALA, and that's a photoactive porphyrin and precursor in the heme pathway. I'm going to refer to it as Cysview just for ease of pronunciation. This enters the intracellular space of urothelial cells, and here it's converted to photoactive porphyrins, specifically protoporphyrin 9. These porphyrins preferentially accumulate in mitochondria of rapidly proliferating neoplastic cells, and this is due to altered enzymatic activity secondary to glycolysis, anaerobic, Upon excitation of blue light, These photoactive porphyrins fluoresce and emit pink light. Here we can see some images of blue light cystoscopy across the top row and white light cystoscopy on the bottom row. Blue light cystoscopy across various studies has a sensitivity of 90+%. Now the specificity is just under 50%. The reason for the low specificity is due to fluorescence seen with other causes, not just malignancy, inflammation, recent BCG, recent resection or biopsy, or simply just tangential lighting. A few contraindications to note are active gross hematuria and drug hypersensitivity or porphyria. If we look more into the data for Cysview, we'll start with an RCT that comes out of MD Anderson by Dr. Grossman, which looked at the impact of blue light cystoscopy on recurrence rates for non-muscle invasive disease. This is a prospective multi-center randomized trial, 551 patients, and they're randomized between TURBT with or without blue light cystoscopy. The initial RCT was for 9 months. There was a study extension protocol that lengthened the median follow-up to 54 months. And between both arms, there's similar rates of adjuvant therapy. The key findings here was there's an increased recurrence-free survival with blue light cystoscopy, 38% versus 32%, not 54 months. There is increased median time to recurrence as well with blue light cystoscopy, 16 months versus 9 months. Next, I'd like to highlight a systematic review and meta-analysis by Dr. Berger coming out of Germany. Now, this was industry sponsored by Photocure. This included 10 studies, 1,345 patients, all of them with confirmed or suspected non-muscle invasive disease undergoing TURBT, initially surveyed with white light, followed by blue light. All of these studies used, except one, within patient comparison, so they did get evaluated with white light followed by blue light. There are two endpoints here. The first being to assess whether the addition of blue light to white light cystoscopy improved tumor detection. And the second endpoint was to determine whether an improved detection rate would reduce the 12-month recurrence rate. Looking at the first point, increased tumor detection rate with blue light cystoscopy was significant. There's 24.9% additional lesions seen with blue light cystoscopy, not visible on white light, for TA or T1 disease. And that number increased to 26.7% additional lesions for CIS disease. Looking at the second endpoint, there was a decreased 12-month recurrence rate with blue light cystoscopy. Key numbers to remember being 34% versus 45% recurrence. And when looked in subgroup analyses across low, intermediate, and high risk non-muscle disease, all of these subgroups were significant still. Here we have the forest plots looking at the tumor detection endpoint for TA and T1 disease. This was covered in 6 of the studies and is significant for high and intermediate risk disease. Now, a small point of clarification, it was not significant for low risk disease for TA-T1, although there is a small amount of patients, only 180 patients in this subgroup, is too small to reach significance. Here are the forest plots similar for CIS, and again, significant. Next, I'd like to contrast those results of Cysview with a paper coming out of the UK by Dr. O'Brien. Now, the key thing to highlight in this study is it combines blue light cystoscopy with intraoperative single-dose chemotherapy. It was a prospective study of 249 patients undergoing TURBT. Follow-up was standardized at 3 and 12 months, and the rates of truly administering mitomycin C were 63% and 77% between arms. The low rate of giving mitomycin was due to concerns for deep resection or ongoing hematuria needing CBI after the resection. There was increased detection of CIS noted with blue light cystoscopy. However, looking at recurrence rates at 3 and 12 months, there was no significant difference with the use of Cysview or not. Now, again, key to highlight that there's a small cohort. Out of the 249 resections, only 185 had non-muscle invasive disease, and the follow-up was relatively short. I wouldn't make any major conclusions from this paper, but it does raise the question of the benefit of Cysview in the setting of single-dose chemotherapy, and that requires further study. If we move on to another technology, narrowband imaging, the indications and guideline recommendations are the same. There's no contraindications. The mechanism of action here is it's actually an optical imaging technology that filters white light into blue light and green light. These wavelengths are strongly absorbed by hemoglobin within vasculature, and then the visual contrast between normal urothelium and highly vascular neoplastic cells is enhanced. The most comprehensive RCT looking at narrowband imaging comes out of Japan and involved 16 countries. It was a prospective study of 965 patients, all randomized to TURBT with and without narrowband assisted cystoscopy, and follow-up standardized at 12 months. Approximately 50% of these patients did receive single-dose intraoperative chemotherapy, the same between arms. The key findings here, there was no significant difference in risk of recurrence using narrowband imaging, 25 versus 27%. Now, there was a decreased risk of recurrence in the low-risk subgroup, which was defined standardly as a solitary low-grade TA lesion under 3 centimeters. It's unclear if this difference truly, though, is due to increased detection with narrowband imaging, or is it actually due to the double mapping, where these patients with small, perhaps difficult to see tumors were surveyed twice, really, one with white light and then once again at the same time with narrowband imaging. We'll change focus slightly here and just scratch the surface of some basic science, looking at novel technologies that are in development. This paper is out of Stanford by Dr. Chang. Molecularly targeted imaging enables the visualization and characterization of biologic processes at the molecular level. It uses fluorescent antibodies, peptides, or other small molecules that bind to tumor surface antigens. One promising agent is CD47, a cell surface protein. It's expressed on more than 80% of bladder cancer cells, but not on luminal cells of normal urothelium. This is shown across the top row of the photo. Ex vivo testing in 26 human bladders post-radical cystectomy using fluorescently tagged CD47 antibodies showed an 83% sensitivity and 91% specificity. If we compare it to Cysview, the sensitivity here is slightly lower, although the specificity is much higher. Another promising agent is pH low insertion peptides. These are membrane binding peptides that cross the cell membrane in acidic extracellular environments, which is more common in malignancy due to high metabolic rate. This is depicted in the photo across the bottom row. In ex vivo testing, again in human bladders post-radical cystectomy, there was a 97% sensitivity and 100% specificity for urothelial carcinoma. This is certainly a very promising field of research. However, it is far from the operating room at this point. Now, to quickly summarize in a few take-home points encompassing enhanced cystoscopy, the use of blue light cystoscopy or Cysview results in improved detection of non-muscle invasive disease, 25% being the take-home number. The greatest benefit here seems to be in the intermediate or higher risk subtypes. There's increased recurrence-free survival. There's an absolute risk reduction of 11%, or a number needed to treat of 9 patients to prevent a recurrence at 1 year. The use of narrowband imaging results in a controversial and questionable impact on recurrence-free survival, possibly a benefit in low-risk disease. Benefits being there's no requirement for preoperative catheterization or installation of an agent. There's also the ability to use narrowband imaging during ureteroscopy for upper tract disease. Conclusion regarding either of these in the setting of single-dose chemotherapy does require further study, however. One thing to note as well is a cost consideration. Cystoscopy is very expensive, about $1,000 or so per installation, I gather, based on American data, versus narrowband imaging is no ongoing cost. However, there's also been a few cost analyses that actually show that cystoscopy may be cost effective, saving costs over the long run by preventing recurrences and ORs subsequently to deal with recurrences. Next, we're going to discuss en bloc TURBT. I find this actually be probably the most interesting and perhaps practice-changing part of this talk. Conventional TURBT, of course, involves a stepwise resection of a bladder tumor, typically using an electrified monopolar loop or perhaps bipolar. Major limitations of conventional TURBT: there's a risk of understaging due to under-resection. Most series describe about a 60 to 70% rate of having detrusor within a specimen. There's a risk of surgical complications, namely bladder perforation. TUR syndrome is possible. Across various series, up to 20% actually report bladder perforation, usually due to obturator reflex. Most series are closer to 5%. There can be complicated pathologic analysis due to fragmentation of tissue and cautery artifact. And then really, conventional TURBT disregards oncologic principles. The stepwise resection through a tumor risks intravesical and perhaps systemic dissemination of malignant cells. To further this final point, there's quite an interesting paper published in the Journal of Urology in 2015. There's 16 patients undergoing TURBT. I don't know why they consented to this, but they had their IVC cannulated by a vascular surgeon prior to resection. Tumor cells were identified in 7 out of the 16 patients from IVC samples before resection. And in these 7 patients, circulating tumor levels actually increased in 6 out of the 7 during resection. Now, this was for muscle invasive disease. It's hard to know if it translates, but it is an interesting topic of discussion. Now, looking at bipolar TURBT, and it involves the same surgical technique, just using bipolar. Possible improvements of this would be reduced risk of bladder perforation due to reduced risk of obturator reflux. Of course, this could be negated by either GA and paralysis or a spinal plus an obturator regional block. It eliminates the risk of TUR syndrome due to the use of isotonic saline. There's perhaps a reduced specimen cautery artifact due to the cooler temperature of a bipolar loop versus monopolar. The clinical outcomes comparing bipolar and conventional monopolar TURBT are conflicting. There was one meta-analysis that favored bipolar for clinical outcomes, both intraoperative, such as obturator kick and perforation, as well as recurrence rates. However, another large meta-analysis found no difference between these two techniques. Looking at en bloc TURBT, the first published en bloc TURBT was actually back in 1997 in Japan, published in the Journal of Urology, so it's certainly not a new technique. It involves resection of the bladder tumor and a circumferential bladder wall margin in a single specimen using any of the modalities, monopolar or bipolar, a variety of lasers, or water jet dissection, which we'll talk a little bit later about. The key surgical steps here include incision of the urothelium to the depth of the muscularis propria, approximately 5 millimeter margin away from tumor. Then progressively dissecting within the muscularis under the tumor to detach the tumor, including it with the bladder wall margin, and then retrieving the tumor through the resectoscope. Some proposed advantages here would be reduced under resection and under staging to minimize surgical complications and to avoid dissemination of malignant cells during resection. Now, it can be technically challenging or sometimes not feasible in the setting of large tumors. Cutoffs in the literature range from 3 to 5 centimeters, simply due to difficulty extracting the tumor. Also, broad-based tumors, either sessile or stout papillary tumors, can be difficult to resect en bloc, and tumor location can be challenging, especially at the dome, anterior bladder wall, or at the bladder neck. Before looking into the data, though, of en bloc, we'll watch 2 videos from the AUA. These describe first monopolar en bloc TURBT, and secondly, bipolar en bloc TURBT. Now, they are narrated, so hopefully the sound works as well.
Here we present several modalities for en bloc TURBT using technologies which are both readily available and those being developed with the hopes of encouraging this technique. Monopolar en bloc excision has been reported with modified resection loops, and in this video is demonstrated with the Stort's sand wedge electrode. The tumor is circumferentially excised and undermined in a controlled fashion. Hemostasis is concurrently achieved. Complication rates in en bloc TURBT, specifically bladder perforation and hematuria, are very low and demonstrated to be less than conventional TURBT in multiple studies. Obturator reflex is generally absent for en bloc resections, and as such, overall perforation rates are very low.
Next for bipolar, a similar video.
En bloc bladder tumor resection can also be performed using the bipolar Collins knife. Bipolar technology has the added benefit of using isotonic irrigation, limiting potential TUR syndrome and more extensive resections. Additionally, the current is confined to the electrode, and so transmission and obturator reflex is unlikely. Comparative studies have demonstrated improved recurrence-free survival and longer time to recurrence relative to conventional TURBT. However, to date, progression rates have been found to be equivocal.
Perfect. We'll now look at the data.
David, can I comment on that? That last statement about recurrence-free survival and progression is total garbage. There's no evidence.
I was going to touch on that.
Okay.
Yes,
just have to pipe that in there.
Yes, yeah. So the definitely no evidence of change in progression. The evidence for recurrence is very questionable. I don't think it's there yet. Perhaps in time. Good. So starting looking at the data, there's an abundance of papers actually looking at en bloc TURBT, and the papers that I've read all come to the same conclusion. Starting here with the systematic review out of Italy. The systematic review has 17 publications included, mainly prospective case series with patients undergoing en bloc TURBT using a variety of modalities. There were 895 patients with a total of almost 1,200 bladder lesions resected. The rate of aborting en bloc resection and converting to conventional TURBT was only 6%. Reasons for this included either difficult tumor location or failure to extract the specimen. Notably, the rate of pathologic specimens that contained detrusor was 96%. This is indirectly compared to many other series of conventional TURBT, where that rate is often in the range of 60 or 70%. There's 1% risk of complications cleaving 3 or higher. Most of these were due to either bladder perforation or hematuria. Certainly based on these numbers, en bloc TURBT seems promising. In order to, though, directly compare en bloc and conventional TURBT, we have a meta-analysis that was published earlier this year. Previously in 2016, there was another meta-analysis that suggested en bloc TURBT had a lower recurrence rate. However, several RCTs since then showed no difference in recurrence rate, and this is the updated meta-analysis from this year. It covers 19 studies and 2,651 patients. Approximately half going en bloc TURBT and the other half undergoing conventional TURBT. En bloc was completed using a variety of modalities again. This first table here is looking at intraoperative complications. On the first line, we can see there's actually no significant difference in operative time with en bloc TURBT. En bloc was also significantly shorter catheterization time, shorter length of stay in hospital, reduced obturator kick, and subsequently reduced risk of bladder perforation. And there's also a decreased requirement for bladder irrigation postoperatively. While there's no significant difference in the rate of residual tumor or positive detrusor within the resection specimen, which was interesting, these results were notable for a remarkably high rate of detrusor within the conventional TURBT arm, 87%, much higher than most series. Now, within the same meta-analysis, looking at recurrence rates, here there is no significant difference in recurrence rates in the low, intermediate, or high risk subgroups of non-muscle invasive disease. However, here we have a forest plot that looks at the recurrence rate within the subgroup that received mitomycin C, the top forest plot being for the 12-month recurrence risk, the bottom being for the 24-month recurrence risk. Now, in this subgroup, it is significant. The numbers are low. All the other chemotherapy agents examined in subgroups were not significant. So I don't think we can conclude yet that en bloc TURBT truly reduces the risk of tumor recurrence. I think that's a question that needs further study. Here we have one final video looking at water jet dissection or hybrid knife. This is also used in endoscopy for GI. It was first published in 2011. It is currently not clinically used in Canada.
A hybrid knife is being investigated for its potential role in en bloc TURBT. The instrument combines a high-pressure no-needle water jet and a monopolar electrode. The desired area of resection is marked using the electrocautery tip. Subsequently, the water jet cannula injects a suburothelial bleb of saline, resulting in the hydrodissection of the involved urothelium, lamina propria, and superficial muscularis off the deeper muscle layer. Electrodissection and en bloc resection of the raised tumor is then carried out. Hemostasis can also be achieved with the hybrid knife. Cautery effect on the specimen is minimal due to the water cushion which hydrodissects the tumor off the muscle base.
Now, the first prospective RCT involving hybrid knife comes out of Germany, led by Dr. Gakis. It involved 115 patients undergoing TURBT randomized to en bloc hybrid knife versus conventional TURBT. Cysview was used in both arms for all resections. Here, the primary endpoint was the proportion of specimens that could be reliably evaluated pathologically for muscle-invasive disease. This was defined as being able to assess the muscularis propria content and tumor margins. There was a significantly increased rate of specimens allowing for adequate pathologic assessment. As well, there was an increased rate of detrusor present in the specimen. However, this was notably lower than for other modalities of en bloc TURBT, and this is theorized perhaps due to the submucosal elevation mechanism involved in hybrid knife. Now, they did show an increased rate of negative surgical margins. However, this is hardly relevant as they're comparing to piecemeal resection of conventional TURBT. In this, there was also increased operative time, nearly double. There's no published long-term data for hybrid knife on recurrence rates, progression rates. The takeaway, I think, is from the EAU consensus statement, which reads, there is a risk of residual disease and understaging when we use hybrid knife for TURBT due to its nature of submucosal elevation. Now, for some take-home points, en bloc TURBT is a well-described technique and has 20 plus years of literature supporting it. Some benefits include an increased rate of detrusor within resection specimens. Typically, the series have over 95%. There's a decreased rate of surgical complications, namely bladder perforation from obturator reflux, as well as gross hematuria. There's also decreased duration of catheterization, length of hospital stay. Now, major drawbacks of en bloc TURBT is it can be very technically challenging or not feasible depending on anatomic factors typically related to tumor location and size. Conclusions regarding the effect of en bloc TURBT on recurrence rates or requirement for re-resection require further study. And I think this last point is interesting. There's no studies to evaluate it, but I think it's conceivable that if an en bloc TURBT specimen achieves negative margins and benign detrusor, then perhaps routine re-resection, which would otherwise be indicated in a conventional TURBT, perhaps would be no longer required.
David, can I pause there before you sort of go forward? These are apparent benefits, right? I mean, the data is subject to, and the whole study is subject to all sorts of biases that cannot be controlled for. Selection biases, surgeon technique biases, the ability to get muscle out of a loop should not be a limiting factor, except sometimes upon tumor location, which isn't going to be affected by your ability to do en bloc. So I think, it's just so similar with so many different attempts to compare benefits of a surgical technique, is that it's so surgeon dependent. As long as you're good at one or the other, then you have to wonder about where the benefits are. And so I think you have to be careful not to be caught in converting apparent benefits into real benefits in your conclusions.
Sure. Yeah, thank you, Dr. Leaf. It is tough. I agree. There are biases through the study, which I think are managed as good as possible, but are still there. And you raise a point. There's studies looking at TURBT completed by residents versus senior residents or staff, and the results are significantly different based on surgeon experience doing the resection, of course. Hopefully in these studies, surgeons doing both en bloc and conventional are technically excellent at both, but there is risk of surgical bias, absolutely.
Yeah. And the other question that was raised is that I think Ben Chu raised, does this alter your need for chemo? And of course, no, it doesn't, right? It's the same thing with all the blue light and others, is shifting landscapes with the routine use of intravesical gemcitabine is going to reduce the risk of seeding, which shouldn't be changed with this operation, I don't think. There's no rationale for it. You can always make up a rationale.
Absolutely, yeah. We'll discuss intravesical chemo a little bit later, but absolutely that's very important in terms of tumor seed and implantation. That wouldn't be changed by this. Perhaps re-resection is the only thing, but there's no evidence yet that we're there yet.
So can I say something there, David? So the original thought behind en bloc was exactly that point, that if you take it out in one piece rather than cutting it in a million pieces, that you would reduce tumor seeding, right? That was the original thought. The advantages with respect to safety and a more intact pathologic specimen, et cetera, those were secondary. So I think there is rationale for why it needs to be tested. I think for now we don't know, and we have to continue doing what we usually do.
But the idea of tumor seeding is, we know tumor cells are seeding, right? Cytology is positive. You go in there and insert a scope, a catheter, you irrigate, you manipulate that papillary tumor one way or the other. You're sloughing tumor cells that may seed up to the dome or will reseed your resected bed. I don't see the difference whether or not it's, then it's just a question of degree. Are you disseminating more tumor cells with a resection, a standard resection versus a en bloc resection?
So positive cytology does not lead to seeding necessarily. We know, where we think we know, that a TURBT causes seeding, and you often get that where you have the air fluid level at the dome, you get a higher rate there. And if you don't have that because you're doing en bloc, you're only cutting around the base of the tumor. You may even be, in a non-invasive tumor, it's even going to be a margin negative resection. You're not cutting into tumor. To me, it makes a lot of sense that you might, you need to see the data, but that you might have less seeding.
Perfect. Well, good points all around. I'm glad we generated some discussion. I'm going to keep moving here now to discuss the optimal management of bladder tumors involving ureteric orifices. We'll start by looking at a brief detour here from non-muscle invasive disease, looking at this paper out of Switzerland, which is in the muscle invasive disease space. There's a retrospective review of 1,000 consecutive patients undergoing radical cystectomy. The aim of the study was to determine if patients are at higher risk of upper tract urothelial carcinoma if retrograde stenting is done prior to radical cystectomy. 22% of patients presented with hydronephrosis prior to radical cystectomy, and of these, approximately 50% had urinary drainage. Of those folks, about half were drained with a double J ureteric stent, and the other half with a percutaneous nephrostomy tube. As part of inclusion criteria, all patients had a negative uteral margin during radical cystectomy. At a median follow-up of 3 years, the rate of metachronous upper tract disease was 3% without drainage, 13% with ureteric stenting, and no patients with nephrostomy drainage developed upper tract disease. Now, the conclusion here is that there is a significantly higher risk of upper tract disease undergoing ureteric stenting prior to radical cystectomy for muscle invasive disease. This begs the question, does this translate to bladder tumor resection for non-muscle invasive disease? To help answer this, there's a nice retrospective review coming out of Germany. It involved 637 patients undergoing TURBT. 19% of these patients required upper tract drainage. Of this cohort, 2/3 underwent double J ureteric stenting, and 1/3 underwent percutaneous nephrostomy insertion. Here at a median follow-up of 15 months, the rate of metachronous upper tract disease was 1%, just under, in the patients without drainage. It was 5.4% in those with a ureteric stent, which was significant. And no patients with a nephrostomy tube developed upper tract disease. Interesting to note as well, the 4 patients who did have a ureteric stent and developed metachronous upper tract disease, all the disease occurred on the same side as the stent. To look at one further study on this topic, there's a paper out of Israel that evaluates the risk of upper tract disease and upper tract obstruction after resecting a ureteric orifice. Here they have 79 patients who underwent a TURBT, which included a ureteric resection. 5 of these actually had bilateral ureteric orifices resected. Patients with preoperative hydronephrosis, preoperative upper tract drainage, either a stent or nephrostomy tube, or intraoperative placement of a ureteric stent during TURBT were excluded. At a median follow-up of 15 months, the rate of postoperative hydronephrosis was 13%. Of these 11 patients, 3 were due to ureteric stricture, 5 were due to muscle-invasive bladder cancer, and 3 resolved spontaneously. So I think the key takeaway from this paper is that the risk of upper tract obstruction and stricture after resecting a ureteric orifice is very low. So to quickly look at a few take-home points on this, the risk of ureteric stricture after resecting the orifice is low, the number being 3.6 in one study. As such, complete tumor resection should not be compromised to avoid resecting the ureteric orifice. An insertion of a double J ureteric stent during TURBT does result in a significantly increased rate of metachronous upper tract disease. And this is even further than we know that patients who have a tumor at the ureteric orifice are at higher risk, but a stent further increases that risk. Now, conclusions regarding the risk of metachronous upper tract disease after stenting in the setting of single-dose intravesical chemotherapy, I think requires further study. There's no data on this. Theoretically, reflux of intravesical urine up a ureteric stent may minimize or negate the risk of upper tract disease, but we need data on this. Now we've talked about the role of enhanced cystoscopy prior to resection. We've talked about en bloc as a method of resection, as well as managing ureteric orifices. The final topic is a question that needs to be answered every time one does a TURBT, and that's whether to give intravesical chemotherapy or not. If we briefly look at the guidelines from the CUA, they actually recommend it for all patients with non-muscle invasive disease. There's a caveat later on in the guidelines saying in those with planned BCG, the benefit is less clear. The AUA says a clinician should at least consider administration. The EAU described a single installation significantly reduces the risk in certain subgroups, which we'll discuss further. Now, looking at the evidence behind these guidelines, probably the most comprehensive review is from Dr. Sylvester coming out of Brussels. This is a systematic review and meta-analyses of 11 RCTs. It covers 2,278 patients, all of them randomized to TURBT with or without single-dose intraoperative intravesical chemotherapy. Some of the studies used a placebo saline installation. The majority of the studies here used mitomycin. A few also used epirubicin, pyrubicin, or thiotepa. The primary outcome here was time to recurrence. The secondary outcomes were progression to muscle-invasive disease and overall survival. Now, there's a lot of data in this paper to highlight the key takeaway points. There's a decrease in risk of recurrence at 5 years from 58% down to 44%. This is significant across all subgroups. It correlates to a number needed to treat of 7 to prevent a recurrence at 5 years. Excuse me, I just said significant to all subgroups. It is not significant to the subgroup of greater than 1 recurrence per year, or an EORTC score over 5. Now the scoring system is the middle column. It is a little bit complex, and we can look at it in more detail later if that's helpful. Caveat being, very few patients were in this subgroup of over 5, only 14% of the cohort or 200 patients, and there were very few patients and recurrences. The majority of these patients were multifocal T1 with tumors greater than 3 centimeters. Here on the left, we have a graph of the time to first recurrence. It shows a significant difference between single-dose chemotherapy in blue and no installation in red. On the right, we have the time to progression. In the study, it was defined as progression to muscle-invasive disease. It's not progression from TA to T1 disease. I'd like to review one final paper before concluding. This RCT was led by Dr. Messing from Rochester. It's a landmark trial that brought intravesical gemcitabine into common practice. Its objective was to determine whether single-dose gemcitabine reduces recurrence in suspected low-grade non-muscle invasive disease when compared to saline. It was a prospective, double-blind, multi-center trial at 406 patients, which were randomized to single-dose gemcitabine or single-dose saline installation. Patients included were suspected low-grade non-muscle invasive disease based on cystoscopic appearance, and these were either patients on initial presentation or for surveillance of previously low-grade disease. 2 grams of gemcitabine were instilled immediately after resection for a 1-hour dwell time. At standardized follow-up of 4 years, there was a significant decreased risk of recurrence of 34% with gemcitabine versus 54% with saline. Even more dramatic, though, I'd say, is the toxicity profile between gemcitabine and saline. If we look here at the adverse events reported between gemcitabine and saline, first, there's no clavien 4-5 complications. There's, in fact, no significant difference between gemcitabine and saline in any category. This suggests that all of the toxicity, mainly lower urinary symptoms or voiding pain, that patients feel are due to the resection, and they're not due to the installation agent. Now, there are no head-to-head comparisons between gemcitabine and other intravesical agents based on comparing studies, which is, of course, difficult to do. They are very comparable in terms of recurrence rate. Now, further, the side effect profile is significantly better than, say, mitomycin C. In addition, I think we have to look at the cost, being in a public healthcare system. The cost of gemcitabine is about 1/20th the cost of mitomycin C. In American numbers, mitomycin is just over $1,000 per dose. Gemcitabine is $56. And I think in Canada it's slightly actually cheaper. Now, a few take-home points. Single-dose intravesical chemotherapy following TURBT is standard of care for suspected non-muscle invasive disease. The numbers to remember are an absolute risk reduction of 14% and number needed to treat of 7 patients to prevent a recurrence at 5 years. And the benefit here is likely highest in the low and intermediate risk categories. There are several studies looking at the mechanism. This is likely ablative effects on residual or missed tumors, as well as inhibition of tumor implantation. Gemcitabine results in similar improvements in recurrence rate compared to previously commonly utilized agents, such as mitomycin C. However, there's an equivalent toxicity profile to saline. I'd like to thank Dr. Bloc for his insights on this topic, and I'm happy to take any questions.